For this video, the focus will be on glaucoma, and we will be talking a lot about intraocular pressure, or IOP. So we will start off by discussing the normal physiologic pathways in place to regulate this pressure and how imbalances in this pathway can lead to elevated intraocular pressure and glaucoma. And then we will briefly discuss open angle glaucoma versus closed angle glaucoma, and then we will dive into the treatments used to correct the elevated intraocular pressure. And many of these should look very familiar, but now we're applying them in the context of the eye. So starting off with the normal regulation of intraocular pressure. So IOP is the result of a homeostatic equilibrium between the formation and drainage of aqueous humor, which is a plasma-like fluid that fills the posterior and anterior chambers of the eye, whose function is to maintain our intraocular pressure and the shape of the eye. So aqueous humor is continuously secreted into the posterior chamber by the ciliary body, and in order to maintain intraocular pressure, this rate of production must be balanced by an equal rate of aqueous humor drainage. So the drainage route for aqueous humor is first through the posterior chamber, then this narrow space between the anterior lens and the posterior iris, through the pupil to then enter that anterior chamber. And from there, the aqueous humor exits the eye through the trabecular meshwork. And this is where most of the aqueous outflow occurs. The secondary route is the uveoscleral drainage, which takes care of the remaining 10 to 20% of aqueous humor. And again, if aqueous humor production and outflow is balanced, then intraocular pressure is maintained within normal limits. But if this isn't balanced and the rate of production doesn't equal the rate of outflow, then intraocular pressure will increase, leading to a glaucoma diagnosis and lead to optic neuropathy and visual field loss from either the intraocular pressure causing ischemia or compression of the optic nerve head and damage and cell death. So we are going to discuss the two main types of glaucoma. The first one we will discuss is open angle glaucoma, which is the most common and refers to this angle here between the iris and the cornea and remaining open, so that this angle required for drainage remains unoccluded by the iris, for example. So open angle glaucoma is more of a chronic progression and is thought to be mainly due to reduced flow through the trabecular meshwork due to degeneration and remodeling of this region from prolonged exposure to elevated intraocular pressures, leading to some degree of obstruction. With this aqueous humor outflow reduced, we have a further imbalance and increases in intraocular pressure over time. Closed angle glaucoma, or CAG, on the other hand, can be acute or chronic, with acute actually being a medical emergency requiring swift intervention to prevent irreversible blindness. As I alluded to previously, closed angle glaucoma no longer maintains this open drainage angle, leading to the iris, for example, obstructing the outflow pathways and leading to a buildup of aqueous humor and increases in intraocular pressure, either acutely or chronically. So even though open angle glaucoma and closed angle glaucoma are different, the two primary treatment strategies employed to restore a balance in intraocular pressure will be generally applicable to both types. And this will include reducing aqueous humor production and promoting outflow of aqueous humor. So we will start at the ciliary body and treatments aimed at reducing aqueous humor production. So moving to our next slide. So in our equation to balance our intraocular pressure, being our production of aqueous humor, which is equal to the outflow. In either type of glaucoma, we have some degree of reduced outflow, whether that is from remodeling and the trabecular meshwork leading to reduced outflow in open-angle glaucoma, or the iris occluding our outflow pathways in closed-angle glaucoma. But regardless, one way in which we can balance the intraocular pressure in and out is by reducing the production of aqueous humor, restoring equilibrium between production and outflow. And we can do this by targeting our ciliary epithelial cells and our ciliary body, because remember, the ciliary body is what is responsible for aqueous humor production. And keep in mind, the ciliary body requires sodium, potassium, ATPases to create an osmotic gradient through active secretion for water to follow solutes into the posterior chamber to form aqueous humor. And this process of aqueous humor production is regulated by both alpha and beta adrenergic receptors, as well as carbonic anhydrase enzymes. And these three regulators can be targeted with therapeutics to reduce aqueous humor production, restoring balance in intraocular pressure. So first, we will discuss our carbonic anhydrase inhibitors, or our CAIs. Since this is a new class of agents we have yet to discuss in a video. So CAIs are the only class of agents we will discuss today that are used to treat glaucoma by either topical routes, so via eye drops, like with dorzolamide, or systemic administration, so PO or IV, like with acetazolamide. So carbonic anhydrase enzymes in the eye are responsible for the conversion of carbon dioxide and water to a carbonic acid, which then dissociates to a proton and bicarbonate ion. And bicarb is an essential ion necessary for the downstream active secretion needed to produce aqueous humor. So in other sites of the body, like in the kidney, carbonic anhydrase is responsible for helping maintain acid-base and fluid balance. So inhibition of carbonic enzymes in the eye via topical application will reduce aqueous humor production by reducing bicarb and the downstream movement of sodium and water into the posterior chamber of the eye. But if administered orally, we will have added systemic effects. As you can imagine, topical administration will come with adverse drug reactions like stinging, burning with administration, blurred vision, and tearing, but the systemic side effects will be limited, unlike with oral agents or IV, and this will include adverse drug reactions like fatigue, depression, GI issues, renal stones, and a number of other concerns that may limit their PO or IV use. So because of the systemic side effects, systemic administration is generally limited to those not able to achieve their intraocular goal with topical administration, or those that require IV because of acute closed-angle glaucoma leading to nausea and vomiting and an inability for them to take oral administration. So topical agents like brinzolamide and dorzolamide are pretty common, but the downside is they are going to require 3 times daily or 4 times daily dosing. Now moving on to more familiar classes of agents, we will start off with our alpha adrenergic agonists, specifically our alpha 2 agonists like brimonidine. Which is applied topically via eye drops, and brimonidine will bind the alpha 2 receptors on the ciliary body cells, which are GPCRs, And I won't go through the signaling cascade, which you should be familiar with already, but through its downstream reduction in cyclic AMP, there is a reduction in aqueous humor production. And it's also thought locally it causes vasoconstriction of the blood vessels, which would also reduce the fluid available for aqueous humor production. So another topical option for glaucoma that reduces our production. So because it's topical, it's mostly local reactions like allergic type reactions, as well as inflammation in the eye and mydriasis. However, some systemic side effects can be noted, especially if the patient is not administering their eye drops correctly. And of note, specifically, brimonidine can cross the blood-brain barrier. So there might be a risk of fatigue, headache, hypotension, and dry mouth if these are not being administered correctly. Also, brimonidine, for example, is TID dosing or 3 times daily dosing, so not ideal for adherence. Our last group of agents on the slide will be our beta-adrenergic antagonists, like timolol, for example. Again, these are going to be given topically, and these agents will bind and block the beta receptors, either non-selectively or through beta-1 receptor selectivity, and prevent them from binding endogenous agonists, and through similar secondary messenger alterations as our alpha-2 agonists will lead to a reduction in aqueous humor production. So again, topically administered, so mostly localized stinging, burning, reduced tear flow, but can have systemic effects that you would expect a beta blocker to have if the eye drops are not administered correctly. But the bonus is these require less frequent dosing compared to the other 2 classes of agents we discussed on this slide. So now moving on to our next slide to discuss our options to restore intraocular pressure balance by increasing aqueous humor outflow. So if we can improve that outflow either through the trabecular meshwork or the uveoscleral pathway, for instance, we can lower that intraocular pressure and restore that equilibrium. And the primary way in which we are able to alter this outflow issue is by using medications that can alter targets that trigger remodeling in the cells and the extracellular matrix involved in these outflow pathways. So the first group of agents we will discuss on this slide that can promote aqueous humor outflow and restore that intraocular pressure balance are our topical prostaglandin analogs, like latanoprost. What's interesting is that very high doses, prostaglandins actually cause inflammation and increase intraocular pressure. But at low doses, like those used in glaucoma, prostaglandins will promote the outflow of aqueous humor, thought to mostly be through the uveoscleral pathway, but some trabecular meshwork pathway as well, and reduce that intraocular pressure. So specifically, latanoprost is a prostaglandin F2 alpha analog that will bind to the prostaglandin F receptor. That is also a GPCR, which again, we won't go in depth into the signaling cascade, but the binding of these prostaglandin analogs to their respective receptor leads to alterations in the expression of things like matrix metalloproteases and others capable of altering the extracellular matrix, as well as relax the ciliary muscle and cause cytoskeletal changes, all of which will fix the remodeling done by this increased intraocular pressure over time to help promote that outflow. So the bonus of this agent is it can be given once daily at night, but it can alter iris pigmentation. So caution if this is going to be used in just one eye. And then a few topical adverse drug reactions, but very minimal systemic side effects, which is a bonus. And these are commonly first choice for chronic treatment because they are cost effective usually, and the once daily dosing improves adherence. And then just one more thing to note, so based on this mechanism of action, you can probably guess that it is going to take a little bit more time to see the maximal effects of these prostaglandin analogs when compared to some of the other agents we've discussed. Now we are going to move on to a relatively newer agent called latanoprostene, which is also known as Vyzulta. And based on this name, you might be thinking this is a prostaglandin analog, right? But this particular agent actually has a dual mechanism of action from its two metabolites. So this agent does have the same beneficial effects as latanoprost, promoting outflow of aqueous humor primarily through that uveoscleral pathway. But now it actually has an additional moiety that generates nitric oxide, which will go through its normal signaling cascade we've discussed before, but downstream in the trabecular meshwork, this will inhibit Rho-A activity, which is a G protein that activates Rho kinase. This inhibitory effect on the Rho kinase pathway leads to cytoskeletal relaxation and reduced cell stiffness, allowing increased outflow through that trabecular meshwork. So it is thought that glaucoma comes with reduced nitric oxide levels, which may contribute to the trabecular meshwork contraction and increase ocular pressure. So we are kind of supplementing what's missing. So this agent will promote outflow through both pathways. So because this agent is very similar to our prostaglandin analogs, be aware that it will have some of the same advantages and disadvantages of this class, with the exception of cost, because this agent is new and we have other cheaper, well-established options. This may be more costly for patients. And this provides a good segue into our topical Rho kinase inhibitor, being Rhopressa or Notarzidil. And this agent will inhibit Rho kinase in the trabecular meshwork and leading to those cytoskeletal rearrangements and reduced cell stiffness to improve aqueous humor outflow through, again, that trabecular meshwork to reduce intraocular pressure and restore balance, just like our nitric oxide moiety from Vyzulta. So with Vyzulta, we talked about the pathway before Rho kinase. But now let's just briefly discuss what happens between Rho kinase and these cytoskeletal rearrangements. So myosin and actin are key components of the cytoskeleton, and phosphorylated myosin interacts with actin, increasing cell stiffness. And as you might expect, this phosphorylation of myosin is regulated by the activity of both a kinase and a phosphatase. So usually Rho kinase would actually inhibit the phosphatase that's responsible for removing this phosphorylation and would allow the relaxation of the cytoskeleton. But with Rho kinase being active, that phosphatase cannot exert that effect. So we have this cell stiffness. But once we can actually inhibit Rho kinase with Notarzidil, that phosphatase is then free to dephosphorylate that myosin so that we can get relaxation in the trabecular meshwork and promote that outflow. So this agent is also dosed once daily in the evenings. which is a bonus for adherence, and usually the expected local adverse drug reactions are the only concern. And just like Vyzulta, this agent is probably going to be pretty expensive for patients for the same reasons we mentioned before. So moving on to our summary slide. So these are not necessarily all of the agents used in glaucoma, but a good majority of the ones that are either newer or commonly prescribed to restore balance and intraocular pressure in glaucoma, in either one or both types of glaucoma. And I will leave it up to you to research their specific indications. So the main takeaway from this video should be that all glaucoma treatments are trying to restore aqueous humor equilibrium through either reduced production or increased outflow, and you should become very familiar with their mechanisms of actions that we discussed today. So there are also a few other additional key points I hope you appreciate from this video. So first, understand that for glaucoma, topical administration is leveraged as a way to deliver concentrated localized therapy. And ideally, if the eye drops are being administered appropriately by the patient, this is going to limit systemic side effects, which you should be able to theorize what these might be based on their mechanism of actions. And if you have a patient that comes to you complaining of these systemic side effects, they may require additional counseling on their administration technique. Which brings me to point 2, which further highlights the importance of adherence in counseling. So because of the pharmacology of these agents, some are going to require once daily dosing, some 4 times daily dosing, and all the options in between. Some are going to be during the day, some at bedtime, some are refrigerated, some are not. And it's very common for patients to be on multiple eye drops, some for one eye, some for both eyes. So taking the time to explain these complicated regimens to patients will be key for adherence. Now, I will mention that there are some combination eye drops that can help simplify this, but these complicated regimens are not always avoidable. So the last thing I would encourage you to do in this video is take a closer look at the IQ patient's eye drop regimen and think about how complicated that could be for a patient trying to remember that without appropriate counseling.